at the back of the handout, these are these are the medicines that, when I think about poor response to treatment, what's next. There are other medicines. Someone mentioned biologics and things like that. So biologics are there are antibodies that are actually made. It can be part human, part mouse, that act against different things in your body. So TNF is a tumor necrosis factor, is a cytokine in your body, and you can make a mouse or human antibody that actually binds to that. It's an inflammatory, so that's like what Remicade is that they were talking about. But those, again, as Craig said, are more used in animal models and are not prime time for humans yet. So I wanted to kind of focus on really what are our options right now, realistically, for patients. So standard therapy is azathioprine with or without prednisone, or few people prednisone alone. I am similar to Dr. Bacon in that I really want to get my patients off prednisone. Prednisone is, my patients generally don't love prednisone, and so try to get down to the lowest dose possible or off if possible. But what's the alternative when those therapies aren't working? And I think when you think about what's the alternative, you have to think about, is a patient really failing treatment, meaning their liver enzymes are either not getting better or getting worse, or is the patient not tolerating treatment, meaning it's a side effect issue? Because that really determines who will respond to other therapies. I'll give you guys a word on budesonide, because I don't think we've talked about it that much yet at the meeting. So budesonide is a steroid that is not as well systemically absorbed as prednisone is. So it was in high favor because maybe we wouldn't have as many steroid side effects if you took budesonide, and it's used in inflammatory bowel disease because since it's not as well absorbed, it works directly in the gut there, and so it's favored there. So there was a study several years ago where they actually took patients and they, with a new diagnosis of autoimmune hepatitis, and they put them on budesonide with azathioprine. And the budesonide is dosed 3 times a day because it has a short half-life, so you can't just take it all at once. And then they put patients on prednisone 40 milligrams plus azathioprine at a dose of about 1 to 2 milligrams per kilogram per day. And this is just one study, and they basically showed that over a 6-month time period that patients achieved better remission on the budesonide in the setting of less side effects. And you wonder, well, if there is that study, why don't we talk about budesonide more? And I think it's because it's only come out of one study. And what they did in that study with the prednisone is they monitored labs every 2 weeks, but they tapered every 2 weeks regardless of what the patient's labs showed. So it wasn't an individualized patient-responsive therapy. Sure, I outlined for my patients a plan of, I'm going to go down by your prednisone by X amount every 2 weeks based on your labs, but if the labs don't get better, then maybe we need to hang out at that dose a little bit longer. And so that study has been criticized because it wasn't a patient response guided, it was just a protocoled study. Additionally, they didn't do any liver biopsies, and then they didn't follow anyone beyond 6 months. And we don't really know, can you taper budesonide or not? So who do we think about budesonide in? Patients mainly with milder disease. So in cirrhosis, so budesonide is about 90-something% metabolized in the liver first pass. So if you have cirrhosis and your blood supply is altered to the liver and your liver's not working as well, you may be getting a lot more budesonide than we actually know. I actually have a patient who was who came to me on it with cirrhosis, who turned out when they tried to stop it, she was adrenally insufficient just from being on budesonide, which we don't think that's absorbed as much. So I think it's one of the things in cirrhosis we generally avoid it. But in patients who have milder disease, who you really anticipate steroid side effects, so someone with bad diabetes already, or someone who is really overweight, and the disease is really mild, I think we can consider it up front in some of those patients. But again, I don't use it nearly as much as my standard therapy, and it's not really for someone who has a poor response to treatment, unless it's just a steroid side effect issue. We've seen that if patients are dependent on prednisone, not intolerant to, that budesonide doesn't really work as well. But there is a role for it, I think, in patients who are intolerant to steroids. So mycophenolate mofetil, I think you guys heard about it in a little bit of a bad light in my pregnancy talk, but I actually like mycophenolate a lot in therapy, and I use it a ton for transplant patients, and I use it in my autoimmune hepatitis patients. It works very quickly. and you take it twice a day. It's not used usually up front, like just at your diagnosis, because one, it's expensive, and then there's not as many trials looking at it up front. There was one trial, I think they had 60 women in there, and it was about, along with prednisone, and about 88% effective in normalizing the liver test, and about 37% could completely come off prednisone. Yeah?
Was that an immune suppressor?
Yes, so it suppresses DNA synthesis. So it actually works at the cell level and blocks DNA purine synthesis. So it's a completely immune suppressant. And so the only downside of it, and the people I caution, is it really is, we do know it's a teratogen, and so women of childbearing age, I try to avoid it. I mean, have I had patients on it? Yes, we do birth control and things like that, and I do think it's a good drug, but we do know it's a known teratogen. The side effects of it are low blood counts, which we know azathioprine can do as well. Some diarrhea and GI side effects. Interestingly, my patients who have GI side effects on azathioprine do not always have GI side effects on mycophenolate, even though if you look at both the bottles, you will see, or labels, you'll see GI side effects. And where mycophenolate mofetil has really been shown to work is in patients who were intolerant to standard therapy. So not patients who fail, not the patients who you have on azathioprine and prednisone and you really can't make their disease get better. Those patients, like that first case where the lady had nausea and daily nausea and vomiting, that is someone I would put on mycophenolate. Anywhere from studies of being 43 to 88% effective in those intolerant patients. The other case that I presented to you guys was a lady, so that lady had the abnormal liver test that kind of developed while she was on therapy. We were tapering the prednisone, but we'd also gone up on the azathioprine. So we actually measured her levels of the 6-TGN, or the therapeutic metabolite of azathioprine. And while that was normal, you also, as Craig said earlier today, get the liver toxic metabolite in that profile, and it was through the roof, greater than 3,000. And we did a liver biopsy just because she'd also been on therapy for a while, and it actually showed drug-induced liver injury. So that you can actually, some people can have a completely idiosyncratic reaction to azathioprine. It's not common, but it's there. And so someone like that, who I know was getting better on therapy, I don't think they failed therapy, that would be someone I switched to mycophenolate, and she has done great on that. When I tell you guys these studies, these are nothing like the azathioprine studies. I mean, I'm telling you that there are 13 patients in some of these studies, and 9 in some of them. So they're not big controlled trials or anything like that. But it's what we've got. When they looked at, when they looked specifically at patients who had failed therapy, one study out of Henry Ford said that no one responded to mycophenolate completely. There was a lowering of the liver test, but complete normalization was not there. And one study said that 25% of people responded. So I think the real niche for mycophenolate, and where I look at it, is people who are really intolerant to azathioprine and have had good success with it.
Isn't that interesting? Because pre-transplant, I was on azathioprine. Post-transplant, I'm on mycophenolate.
Yeah.
And you mentioned that mycophenolate can also lower your blood levels.
Yeah.
Would that include my platelets and stuff?
Mm-hmm.
Because my platelets are 43.
Yeah. So
Yes.
platelets can go low for a number of reasons. The medication, so mycophenolate, or it can be as your scarring progresses in your liver.
Right.
So your spleen can be big.
Well, I've got,
And
I
so
have an enlarged spleen, but I also had a blood clot in between my portal vein and my spleen.
Yeah.
So, and because that clot is still there, that kind of caused my spleen to enlarge.
Right. And so the spleen is a sequester of platelets. So the bigger the spleen is, it eats up your platelets. So that goes down. The other thing is your liver produces thrombopoietin, which is a stimulant for platelets. So not unless you have more advanced liver disease, but like cirrhosis, the platelets are low for twofold reasons, usually a big spleen and because your liver is not helping with the platelet production. But then you have medications on top of it that can lower it. So you do have, similar to azathioprine, you need to monitor blood counts. And we don't pay, sometimes we do additive therapies, but you don't put azathioprine and mycophenolate on together because they have the same, so you're going to have really low blood counts. They're both, they both kind of work at the same pathway in terms of immunosuppression, so we don't use them together.
Can you talk to us a little about budesonide and mycophenolate?
Yeah, so I'm trying to think if I have, I don't have that many patients on a combination of budesonide and mycophenolate. I think I have a couple as I was just thinking about it. My goal ultimately is to try to see if I can get patients off steroids completely. But I think it's what the patient responds to. They don't interact with each other. They work down different pathways. So it's fine to have a combination of them. The question is the disease controlled? And we say normal liver test, but we're really talking about the fibrosis in the liver, and can we regress the fibrosis or improve it as well? So I think if there's no reason you can't use those two together because they work down different pathways. The last case I presented to you guys was not someone she was tolerating her medicines just fine. It's just we couldn't get the prednisone down. And she's young to be on a lot of prednisone. So that's when we start to look to these drugs called the calcineurin inhibitors. And they're immunosuppressants. And we use them a lot in the transplant setting. So tacrolimus and cyclosporin are the main ones you guys will hear about if you hear about them. They work. They work very well. The downside is, and the reason we don't use them in just patients who are treatment naive, not just poor responders, is because they do have a decent side effect profile. Now, we use them in hundreds and hundreds and hundreds of transplant patients, so they're safe, but they have been associated with some kidney injury, high blood pressure, and actually diabetes. A risk of malignancy, mainly non-melanoma skin cancers, and high cholesterol, as well as some neurologic complications.
Yeah. When you say neurologic complications, what does that mean? Because I've been taking hormone transplants since I was 12 again, or 13-ish.
So not long-term, like you're going to lose your memory type things, but it's more some patients have tremors from it. Some patients feel like, I've seen seizures from it. Some patients just feel like they're a little bit more clouded. It's usually up front, and it's hard to tell. There's no way, there's no MRI you can do with the brain or anything to figure it out. But it's usually and just because they both do it, you can switch between cyclosporin and tacrolimus, and one may not do it and the other may. And so I don't usually use them up front because they also are dosed by a level. It's not so much. We don't monitor the levels really to know if you're therapeutic. We monitor them to prevent you from being toxic. Now, transplant's a different story. We do aim for specific levels, but in autoimmune hepatitis, we want the lowest dose possible that controls your disease. So we tend to use lower doses, and we've seen that even lower levels are okay in autoimmune hepatitis. It is really effective in 85 to 93% of treatment failure, so it is an effective drug. Yeah, go ahead.
Do you use the tacrolimus with other medications?
Mm-hmm. So exactly. So in that patient that I showed you guys, the pregnant patient on prednisone and azathioprine, what I would do for her is add on tacrolimus there to her regimen. Yeah, exactly. And then I'd try to get her down on prednisone next. And then if I could, and I can in many scenarios, then get the azathioprine off in those patients. And now transplant's a different setting. People are on multiple immunosuppressants. But you can add, I usually add it on and then back off. And it's fine for drug intolerant patients. It's just that it does have more side effects, and you do have to monitor it more frequently. So mycophenolate works very well for those. So that is usually my first line. It's mycophenolate for patients who are intolerant, but then people have a poor response in terms of liver enzymes not getting better, the disease not getting better. Then I think about the calcineurin inhibitors. So the last few sentences, and you guys can just read, is just kind of my general approach to autoimmune hepatitis. And remember, I find this is hard to put in a table. You can't put all this in a table, and you can't, so take it to the table for what it's worth, and you can't put your approach in 4 lines because it varies. My fellows always ask me, well, how do you do this? How often do you monitor? And I say it depends on the patient and how the patient's doing and side effects. And it's response guided and it's individualized. It's the most important thing. The goal, I say, is normal liver enzymes, and then, of course, I'm saying, well, liver enzymes normal isn't always perfect when I'm answering a question earlier, but it's really it's really absence of progression of fibrosis, right, or even improvement in fibrosis, but we use liver enzymes and immunoglobulins as a surrogate of that. And then I usually, begin with prednisone, add on the azathioprine. I try to get it to 2 milligrams per kilogram per day, and I try to get people off prednisone within a few months. 3 months is pretty fast, and I can't get everyone off prednisone, but I do really work to get it off. If a patient really has side effects, and the ones I've mainly seen, and you guys can tell me more nausea, vomiting, low blood counts, pain, and even if patients have low blood counts on AZA, it doesn't mean they're going to have low blood counts on mycophenolate. So it's okay to switch those two. I've seen liver toxicity, rash, and just some general arthralgia, kind of arthritis type pain on azathioprine. If that happens, usually mycophenolate works, except if women are pregnant. And then if you're really on full dose azathioprine and you still can't get down below 15, 20 milligrams of prednisone, then it's really moving to cyclosporin or tacrolimus. So that's my general approach, but you guys tell me, and you guys ask me questions. Yes. Yes.
Okay, I don't have one of those.
Oh, so sorry. Yeah.
Yeah, well, it's too late to read now, but I'll just ask you. Thank you. I'm on a combination of azathioprine and allopurinol, and I don't see too many people on that. And I've read a lot of side effects, like if you use these two together, and I'm like really scared, like what kind of, because it's like bone marrow suppression. That's like the biggest concern.
Yeah.
So is there like any tests that you have to do with these two?
So it's a good question. So I wish I had a picture for you all, but allopurinol it affects the metabolism of azathioprine, and the way it affects it. So we don't have as much data on monitoring levels of azathioprine in patients with autoimmune hepatitis. They do it routinely in inflammatory bowel disease. It is expensive, and those lab tests are expensive. And I think if people are responding, then we don't need to measure those levels. So I think you can over-measure. I mean, we love data, but you can over-measure things. But if people aren't responding, you can consider checking the 6-thioguanine, which I think Craig talked about earlier, which is the therapeutic metabolite, and you want that closer to 240. Some people are just, for some reason, metabolizers in such a way that they shunt down the pathway where they cannot get that therapeutic level. If you add on allopurinol, it actually makes you go down that pathway of getting the therapeutic level, the way they interact together. So it can help promote you getting a therapeutic level, but you have to watch more closely for the bone marrow suppression. So, I actually check a thiopurine methyltransferase, or a TPMT, in my patients up front. I don't know if you guys have had that checked. It'll tell you whether you're more prone to getting the low blood counts with the azathioprine, and that's just a one-time test. And people, it's debatable whether you should check that or not, but it is available, and I think it is helpful as you're pushing the dose. So I wouldn't put someone who has that deficiency on there, because they're going to be much more prone to low white counts. You just have to be more cautious and monitor. But if your counts are okay, and it's getting you a therapeutic level, and it's controlling your disease, then that's okay. But they just would be following your levels of 6-TGN and then following your blood counts. But it is safe to use the combination. It's just it requires more monitoring, and it's a little bit harder. So. You can think about other therapies, but allopurinol is a safe med, and you're on the younger side, so, it's a reasonable combination and something you will use.
When my hepatologist prescribed, I had no idea, and then I went for a refill, and I had to ask my GP.
Yeah.
And she was like, there's no way I'm going to prescribe that with it. I was like, okay, I have to go to my hepatologist again.
No, there was, and for right reasons, they counsel regarding the interaction, which if you don't have experience prescribing it, you wouldn't know, but your hepatologist actually wants that interaction, wants to make you more therapeutic. So, yeah. Mm-hmm.
So, I have a question. So, I've been in chemical remission for 5 years. So, how often do you see a patient that's been in chemical remission for 5 years and then all of a sudden, okay, it stops working and you have to do something?
It's rare, but I think they showed that case. Someone, and that's why we do follow your labs still regularly, even if you're in remission, and see you every 6 months to once a year in terms of meds, because it can happen. And sometimes it happens, and you treat with prednisone, and you can still get the disease under control, even getting back to close to even if it's a slight adjustment in the azathioprine that you're on, or a slight increase in the mycophenolate. I just had a lady who's been stable for 5 years. I'd spaced her labs out every 6 months, and all of a sudden she flared. And I have her on just one extra little pill of mycophenolate a day than she was on before, and she's completely controlled again. So it doesn't mean that just because if you do flare 5 years out, that it's going to be impossible to control or anything like that. And the question is, why do people flare? I mean, you think certain viral infections may trigger, a flare. A medication may trigger a flare. So I think that we know that if patients get in remission, it's a better, prognosis and less likely to flare, but it still can happen because we still don't understand the mechanisms.